Now let me move on to my topic, which is the top 10 trials at Mount Sinai Fuster Heart Hospital. And I'm going to go through this relatively quickly just to get us back on time so that we can have the lunch break as planned and an opportunity to see the exhibits and so forth. These are my disclosures, and I will be covering some trials where the research funding does come in to Mount Sinai under my name for trials I'm involved with. And you'll see which trials my name will be listed there. So let me start first with some innovations in Mount Sinai Fuster Heart Hospital. Just this past June, we had a supplement in Science come out that detailed some, not all, of the different cardiovascular research going on at Mount Sinai Fuster Heart. And one of the topics had to do with cardiovascular trials. And there are a number of trials that are ongoing. Again, for the sake of time, I'm not going to be able to go through everything going on here at Mount Sinai and focusing on some of them, but a lot of them are targeting this concept of residual cardiovascular risk. Touched upon it a little bit this morning, but if the LDL is already pretty well controlled on a statin and someone's on aspirin and so forth, can we do more with respect to reducing their cardiovascular risk? Because we know even the most optimally treated patients in contemporary trials, they're still having events that are pretty high. So that's a series of trials that are summarized in that Science supplement about that. And other topics, also trials going on in the realm of imaging and using AI, and I'll touch upon some of that. But also research going on here, not just about trials, but trial designs. That's trying to optimize trials, trying to make the process of discovery more efficient, more effective, safer for patients. Also, a lot going on here is detailed in that Science supplement about promoting cardiovascular health, in particular through education and of young people. Dr. Fuster touched upon that in his talk. And something no one's really going to talk about much at today's symposium, which is very clinically oriented, but there's also a lot of basic and translational science going on at Mount Sinai Fuster Heart, in particular having to do with metabolic and immune and neuronal pathways in atherosclerosis, also having to do with that heart, brain, and immune system interaction. Great research going on here as well with respect to AI and genomics and intravascular imaging in the cath lab. You met Drs. Kinney and Sharma a little earlier at the start of the symposium. They're leading a lot of that research. But now let me move to the top 10 trials. And for any Mount Sinai faculty where I didn't include your trials, I apologize. I could only fit in so much here. And I really focused on trials that our faculty are actually leading, not just participating in. And start with the Victorian 2 Prevent, a trial that Dr. Moran is on the executive committee for. That's an important trial looking at secondary prevention patients, so patients that have cardiovascular disease randomized to the siRNA PCSK9 cholesterol-lowering injectable drug known as inclisiran versus placebo. The trial is fully enrolled, and hopefully the results will be out sometime in the next year or two. This is an important study to see whether that approach, which has great theoretical appeal, giving an injection in the doctor's office every 6 months, where you would hope that the adherence rates would be very high, might then result in a reduction in cardiovascular events. That's Victorian 2 Prevent. Victorian 1 Prevent's a trial I'm chairing that is looking at the same drug versus placebo, inclisiran versus placebo, but in primary prevention, that is lower down the risk ladder. You heard Dr. Martin mention that'll be presented at the AHA. That's sort of been billed as a primary prevention trial in the medical press, but that's actually not really accurate. It's, for the most part, a secondary prevention trial, but this is a dedicated primary prevention trial. It's fully enrolled, 14,000 patients as of last November. Of course, these are low event rate trials, so it'll be several years before the results are known, the events accrue. Another trial having to do with LDL lowering and inclisiran, Dr. Fuster did briefly mention this, is the PRECAD trial that he's leading, taking young folks and seeing if aggressive LDL lowering is able to prevent plaque progression as assessed by 3D vascular ultrasound. Of course, in young people, you can't really do an event-based trial. It would have to be tens of thousands of patients followed for a decade or so. So in lieu of looking at clinical events, plaque progression is the endpoint here. But using the 3D ultrasound that he'd alluded to before. As well, in the launching phase is the intervention that Dr. Moran and Dr. Banaka from Colorado are leading. This is a really important trial, again, looking at potent LDL lowering with an siRNA and inclisiran versus placebo, in this case in patients with coronary or peripheral revascularization. And, it's an important population because at large centers like this, we do a lot of coronary and peripheral revascularization. The technical expertise, the results are outstanding, but can we do more than just put them on a statin and whatever antithrombotic regimen they're on? Can we really aggressively lower LDL cholesterol and further reduce events? So that's an important trial. Another trial that Dr. Moran is chairing along in this case with Dr. Adrian Hernandez from Duke is the Artemis trial. And this is an important conceptual trial looking at whether inflammation really matters. We talked a bit about inflammation. Dr. Martin showed some data about that as well. And the importance of it. But here, the goal is to look at an interleukin-6 inhibitor, ziltivekimab is its name, versus placebo in patients with a STEMI or an NSTEMI to see if it reduces cardiovascular events. So important, of course, just in terms of valuing this drug, but even beyond that to see, is inflammation a modifiable risk factor in the context of acute coronary syndromes? Other trials that are ongoing have to do with the coronary sinus reducer. I don't know if everyone's familiar with that. It's a device that looks sort of like a stent that can be put in a coronary sinus. It's approved in some parts of the world, not in the US, for treating refractory angina. It's an interesting sort of a device. This is a recent editorial with one of our fellows, Michael Vavronakis, where we review the data and sort of conclude that there needs to be more data. That is, the trials to date have been a little bit shaky, if one is being honest, with a lot of mixed signals about whether it works or not. And in fact, there is a trial that's ongoing that Greg Stone, one of our faculty members here, along with Tim Henry, is leading, the COSIRA-2 trial. It's a sham control trial, which is the right way to do these sorts of trials, versus this coronary sinus reducer to see what the effect might be on clinical endpoints. And the fact that it's sham controlled, I think, allows a real assessment of things like exercise time on the treadmill, quality of life, et cetera. Another trial that is being led out of here is PROTECT 4 by Dr. Stone. Again, this is a trial of patients that are randomized after undergoing coronary intervention, either for chronic coronary syndrome or an ACS, to either mechanical support, specifically the Impella device, or control. And I think that'll be important to really nail down what the role is of mechanical support. These devices are expensive. They do tend to generate a lot of complications, and whether they really do have a broad role in complex interventional procedures or high-risk interventional procedures really remains a matter of debate. Another program led by Dr. Stone here and Dr. Godino from one of Dr. Harrington's faculty, a cardiothoracic surgeon from Cornell, is the RECHARGE trial. And this is looking at that age-old question of PCI versus CABG, but in a newer context, in the context specifically of women and underrepresented racial and ethnic minorities, basically Black and Hispanic patients, to see which one might be better. And not just looking at the usual sort of thing, death, MI, stroke, that's been studied quite extensively, but also things like quality of life, patient-centric endpoints, really important to assess. Another trial I'll mention, one that I'm chairing, Dr. Moran's on our executive committee, is the SOS-AMI trial. This is a trial of selatogrel, which is an injectable ADP receptor antagonist, so clopidogrel, prasugrel, ticagrelor, oral agents, cangrelor, intravenous. This you give subcutaneously, and when I say you give, I actually mean you give. So what's being studied here, I think, is an intriguing concept. The idea of a patient with a history of an MI who is then randomized to carry around an injectable antiplatelet versus a placebo-containing cartridge. And the idea is if they think they're having another MI, to self-inject themselves, sort of like an EpiPen. If a patient thinks they're having an allergic reaction, someone near them, their loved one or someone would inject them to try to abort the allergic reaction from progressing. It's the same concept here. If the patient who has previously had an MI, who maybe has some sense of what the symptoms are like, feel they're experiencing those sorts of symptoms again, they would self-inject themselves and call 911. I don't know if this drug will actually work for this indication or not. That's why we're doing a large randomized clinical trial. But I think the concept is really quite provocative. The idea of patients administering therapies for themselves in the context of acute coronary syndromes. And I suspect, as has happened with allergic reactions in the EpiPen, that this will find a role in cardiovascular medicine, if not for this drug, for other drugs in the context of ACS, arrhythmia, atrial fibrillation, SVTs, and so forth. So I do believe this will change the paradigm in terms of who can initiate therapy and when, that is, giving the patient some control of their care. I also think this is SOS-AMI1. Maybe there will be an SOS-AMI2, maybe not, but I think if there were, the idea of coupling wearables with this approach, to me, is really exciting. That is not just relying on the patient to say, yeah, I think I'm having another heart attack, but rather to couple that with different monitoring, ECG monitoring off the smartwatch, a variety of different, looking at different vital signs, maybe using AI to help gauge the probability that it's a real event, to guide the patient whether they should or should not inject whatever the therapy might be. So at any rate, we've enrolled about 10,000 or so patients and about another 10,000 or more so to go. And then now another trial I'll mention here that is being led out of Mount Sinai. I'm chairing it. David Marin, who's the head of prevention at Stanford, is co-chairing it. Bob Harrington's the chair of our data safety monitoring board, is the TRANSFORM trial. And this is a trial of primary prevention type patients, 7,500 of them, who are being randomized to one of two treatment arms, either to usual guideline-based care, doing whatever the guidelines say, treat the cholesterol with a statin, treat the blood pressure, do whatever the guidelines are saying is good to do, or to CT angiography-based care, where their arteries are imaged non-invasively, and then depending on what is seen, their medical therapy is tailored or fine-tuned, essentially using FDA-approved medicines, but in ways that go beyond what the evidence or the labeling or the guidelines would suggest. So, for example, using things like SGLT2 inhibitors, but in patients without diabetes, or heart failure, using icosapent ethyl, but in patients not necessarily with elevated triglycerides, using PCSK9 inhibitors, but in patients that have LDL levels that fall within the guideline ranges. So basically doing things that aren't totally proven, but with drugs that are known to be safe in other contexts. And then there are three parts of the trial. The first is Transform Predict. And the idea is just to see if we actually look at plaque, is that better than, say, using the ACC-AHA risk score or the PREVENT risk score or whatever other risk scores people like, which oftentimes in clinical practice aren't really used, but in theory could and should be. So can we do better in terms of predicting future cardiovascular events? That's Transform Predict. Then there's Transform Plaque, and the idea there is to see if we can cause plaque progression to be diminished, lessened in terms of the aggressive medical therapy that we're using in the investigational arm. And I didn't mention, but there's a CT that's obtained at baseline, but there's also a follow-up CT at 2 years. So the idea with Transform Plaque is to see, can we keep the plaque from progressing? The control arm, in fact, also does have a CT, it's a blinded CT, but there is a CT at baseline and at 2 years, so we would analyze that at the end of the trial. And then sort of the aspirational goal is Transform Outcomes, to see whether this strategy of looking for plaque and acting on plaque actually improves cardiovascular outcomes. And that's a pretty ambitious goal, but we're going to see what it shows. And if the trial is clearly positive, hopefully it'll change care. And if it's negative, hopefully it'll keep this proliferation of CT angiography that's going on in asymptomatic, otherwise healthy people from continuing, because obviously there are healthcare costs to that, and there are also potential downstream consequences in terms of unnecessary invasive procedures, complications from procedures, and so forth. And the idea really is to stage plaque so that if there's stage 0, meaning no plaque in green, that's pretty good. On the other hand, if it's stage 3 plaque in red, that's pretty bad because that correlates with a pretty high rate of events. So ultimately then, the hope is to see whether we can elevate heart attack prevention to the level of cancer prevention, much like mammography, colonoscopy, and in smokers, lung CT scanning are evidence-based on randomized clinical trials, insurer covered, and in the guidelines for primary prevention. Our hope is, if the trial is positive, that we can do the same thing and transform how coronary artery disease is prevented. Well, with that, I'd like to thank you for your attention. Thank you for attending the morning part of this symposium.